Hello everyone. Last class we studied common fractures of shoulder and elbow. Next, let's take a look at the dislocation and soft tissue injuries that are prone to occur in the shoulder and elbow. First of all, let's study shoulder dislocation. Shoulder dislocations occur frequently in young adults, more often in males than in females, and anterior and posterior dislocations are common, with the former being more common. Let's take a look at the etiology and pathology of dislocation. Taking the anterior dislocation as the example, indirect or direct violence can cause anterior shoulder dislocation, but indirect violence is the most common, which can be divided into: first, conduction violence. When the patient falls anterolaterally, the palm supports the ground, the humeral shaft is in an abduction posture. The violence conducted from the palm to the humeral head can break through the anterior wall of the articular capsule. If the violence is strong or continuous, the humeral head may be pushed to the subcoracoid or subclavian position, resulting in a subcoracoid dislocation or subclavian dislocation. For the individual with very strong violence, the humeral head may break into the thoracic cavity, forming an intrathoracic dislocation. Secondly, leverage violence. When the upper arm is hyperducted and extended after lateral rotation, the humeral neck or greater tuberosity of the humerus resists the acromion and slips the humeral head toward to the infraglenoid, forming a subglenoid dislocation, which can also continue to slip to the anterior scapula to cause a subcoracoid dislocation. Because the great tubercle is impaired during shoulder dislocation, it is often associated with fractures of greater tuberosity of humerus. Posterior dislocation of the shoulder joint is common in electrical injury, epilepsy, and other conditions. Direct violence directly hits the humeral head from the anterior to posterior, so that the humeral head bursts through the posterior wall of the articular capsule and slips into the scapular glenoid with glenoid labrum cartilage. Patients caused by indirect violence are generally strong medial rotation fore of upper arm, with palm supporting on the ground, and the conduction violence causes the posterior dislocation of humeral head. It is often accompanied by displaced fracture of the anterior humeral head or scapular spine fractures. So, how should it be diagnosed in clinical practice? Previously, we have studied that the unique signs of dislocation includes ectopic articular head, empty glenoid, and spatial deformity, as well as shoulder dislocation. Expect for general symptoms such as shoulder pain, swelling, and dysfunction. Since the humeral head dislocates from the glenoid and the deltoid collapse, a typical square shoulder deformity is formed. At the same time, there is a palpable emptiness under the acromion, and the humeral head is protruded and palpable in the axilla. There is a significant abduction and medial rotation deformity for the upper arm, with elastic flexation and positive Dugas. X-ray examination can confirm the diagnosis of shoulder dislocation and can examine the presence or absence of combined fractures, but the missed diagnosis of posterior dislocation is high, so the imaging examination should be perfected. Next, let's take a look at the treatment of shoulder dislocation. For French anterior shoulder dislocation, manipulative reduction combined with external flexation should be performed as early as possible. Please watch the video.
Reduction of shoulder joint dislocation. The patient was supine and the orbit was protected by cotton pads. The operator supports the patient's axilla with the epicynary heel, holds the limb in the abduction position, continuous traction, and then gradually adducts and rotates internally. Feel a snap, it indicates the successful, and fix the limb at 90 degrees of elbow flexion.
If it is severe shoulder dislocation with shoulder fracture, or the anterior shoulder dislocation with fracture or manipulative reduction failure, surgical treatment can be used. Next, let's continue to study the subluxation of radial head. Subluxation of radial head occurs mostly in young children under 4 years of age and is mostly caused by traction of the wrist and forearm, so it is also known as nursemaid elbow. First, let's take a look at the etiology of subluxation of radial head. Since the radial head development is not yet sound in early childhood, the diameter of capitulum radial and radial neck is basically same, while the annular ligaments are relatively relaxed and cannot stabilize the radial head. When the elbow joint is an extension and forearm pronation position, the rest of forearm is suddenly pulled longitudinally, and the radial head may be dislocated inferiorly from the annular ligament, and then the subluxation of radial head is formed. So, what are the clinical manifestations of subluxation of radial head? Generally, the child has a clear history of traction injury, and after the occurrence of dislocation, the child cries and refuses the activity and use of the injured limb. The elbow joint is slightly flexed or extended, and the forearm is in the pronation position. The tenderness on the lateral radial head is evident. X-ray usually has no abnormal finding, but it is easy to distinguish from other elbow injuries. Next, we will study the treatment of subluxation of radial head. Manipulative reduction is usually used clinically to treat subluxation of radial head. Manipulative reduction is usually used clinically to treat subluxation of radial head. The specific reduction method is as follows. The surgeon lifts and holds the forearm with one hand, flexes the elbow joint by about 90 degrees, and pushes the longitudinal axis of the radius against the lower end of the humerus. Hold the medial side of the elbow with another palm and place the thumb at the capitulum radial for compression. After rapid rotation of the forearm, there is usually a bouncy sensation at the pinched thumb, indicating the reduction of the capitulum radii. After reduction, the upper limb can be suspended with a triangular bandage for 3 to 5 days to reduce activity and prevent habitual subluxation. Here, we should have a certain understanding of shoulder and elbow dislocation. Next, we will study soft tissue injuries of shoulder and elbow. First, we will study scapulohumeral pariarthritis. Scapulohumeral pariarthritis is caused by shoulder joint pain and movement dysfunction due to soft tissue lesions around the shoulder joint. It is often occurs in patients over 14 years old, more often in females than males, and in left shoulders than right shoulders, and is also known as exposed shoulder wound or leaking shoulder wound. So, how is scapulohumeral pariarthritis formed? The specific etiology of scapulohumeral pariarthritis is still unclear, and it is generally believed that it may be caused by a wide range of chronic aseptic inflammatory reaction occurring in the soft insoles around the shoulder joint, resulting in extensive adhesion of soft tissues and limiting the movement of the shoulder joint. The pathologic process of scapulohumeral pariarthritis can be divided into 3 phases. Acute stage. The lesions are mainly located in the articular capsule. Shoulder arthrography shows tightening of the articular capsule and adhesions between the long tendon or biceps branching and the tendon sheath. This is followed by the adhesive stage. The periarticular soft tissues are involved with the congestion and thickness of synovium as well as the lack of elasticity in tissues. Contracture of the coracohumeral ligament causes contracture of the tissue around the shoulder and extensive adhesion of the soft tissue around the shoulder, which further causes severe limitation of joint motion. Finally, it enters the remission stage. After about 7 to 12 months, the inflammation gradually subsides, the pain disappears, and the shoulder joint function gradually recovers. TCM believes that the middle-aged and elderly people suffer from shoulder pain and unfavorable activities due to deficiency of liver and kidney, insufficiency of qi and blood, invasion of wind called witness evil wire deficiency, and obstruction of meridians, followed by poor qi blood circulation and loss of nourishment in muscles for a long time, resulting in shoulder muscular atrophy. Next, let's take a look at the clinical manifestation of scapulohumeral pariarthritis. Scapulohumeral pariarthritis is generally chronic, and most of them have no history of trauma. The main symptoms are gradually increasing shoulder pain and joint motion disorders. The pain is generally located at the lateral shoulder and sometimes may radiate to the elbow, hand, and scapular region without sensory disturbance. The pain worsens at night. Continuous pain may cause muscle spasms and atrophy. There is a tenderness at anterior and posterior shoulder, subenchromic and deltoid stop, and the tenderness at long-turned or bicep reaching is the most obvious. Then, we will explain the clinical manifestations of each stage in detail. The first is the acute stage. The course of disease is about 1 to 6 months. Shoulder pain and limited shoulder joint motion are predominant. This is followed by the adhesive stage. The course of disease is about 6 to 12 months. The patient's pain symptoms have been significantly reduced, mainly manifested as severe limitation of shoulder joint motion. During abduction and forward flexation, the scapula will swing with shrug. The final is the remission stage with the reduction of pain and the gradual elimination of contracture and adhesion. The shoulder joint returns to normal function. Scapulohumeral pariarthritis needs to be differentiated from the rotator cuff injury. In belief, active and passive motions of scapulohumeral pariarthritis are all limited, while early active motion of rotator cuff injury is limited and passive motion is normal. Finally, let's take a look at the treatment of scapulohumeral pariarthritis. Scapulohumeral pariarthritis can heal spontaneously, but it's easy to occur with a better prognosis. Manipulative therapy is the main treatment, combined with drug, acupuncture, exercise, physiotherapy, and other treatments. The better efficacy can be achieved. If long-term conservative treatment is ineffective, surgical treatment may be considered. Next, we continue to study the common soft tissue injuries of the elbow, lateral epicondylitis. Lateral epicondylitis is a disease characterized by lateral elbow pain, aggravated pain during lifting and forearm torsion as the main symptoms, and the pain may sometimes radiate to the anterior arm. Because tennis players commonly have this disease, it is also known as tennis elbow. It is more common in patients with excessive wrist extension movements or long-term forearm lifting, such as housewives and typists. So, how does this disease occur? Lateral epicondylitis is mainly a chronic avulsion strain of the origin of forearm extensor. Rapid muscle contraction past the muscle origin causes cumulative injury. TCM believes that the occurrence of disease is related to the weakness of qi and blood, failing of blood to nourish tendons, and tender and vessel malnourishment in patients. Clinically, the main manifestation of lateral epicondylitis is that the patient complains of lateral elbow pain, which may sometimes affect both sides and often radiate to the anterior arm. During the examination, tenderness may be found at the origin of the extensor carpi radialis brevis, namely the upper out part of the elbow joint. The range of motion is normal and local swelling is uncommon. X-ray generally appears normal. Finally, it is the treatment of lateral epicondylitis. Patients with mild symptoms can be relieved by appropriate rest with physiotherapy and drug treatment. Commonly used methods include local blocking. However, a small number of patients fail to respond to blocking treatment and can be treated with physiotherapy and immobilization with a plaster support to relieve aseptic inflammation. Lateral epicondylitis is a self-limited disease. Non-surgical treatment is often effective. Surgical methods are rarely used. Only for very few patients whose symptoms are too severe and the non-surgical treatment is ineffective. Well, that's all for this lesson. I hope you can actively review it after class. Thank you.